understanding that when blood clots in the tubes, it can reduce flow. And so when that happens, we looked at how should we evaluate this in terms of looking at it from an outcomes perspective. And there's articles in the literature about tamponade and effusions and hemothorax, but we decided to look at this all as one complex, which we called the retained blood complex. And you can look at this either as an acute problem, a subacute problem, or a chronic problem. And one of the findings that I hadn't really thought of much before until we started looking into this is that the blood that's left behind ultimately can contribute to these effusions that we later see in the postoperative, that is subacute blood, fluid. And how does this work? As you know, when blood first comes out of the blood vessels, it does a clot. But once the clotting cascade kicks in, it's going to develop thrombin. Thrombin is a very pro-inflammatory agent. And one of the things it does, when thrombin gets on the pleural or the pericardial mesothelial spaces, it causes an upregulation of cytokines and other inflammatory mediators, but one of them is vascular endothelial cell growth factor. Now we know VEGF from the angiogenesis type of literature, but when you look at it in the cancer literature and some of these other places, it's a very potent permeability factor. And when they do studies looking at fusions and they look at what sort of cytokines are in them, the VEGF levels go up. So ultimately this blood can contribute to the effusions that we often see through this pro-inflammatory cascade.